You take a sip of ice water or coffee, or you bite into something cold, and for a split second you feel it. That sharp, sudden jolt right in your tooth. Tooth sensitivity is one of the most common things I hear about in this office. And for a lot of people, it's been going on for years. They've just learned to live with it. But sensitivity isn't something you have to tolerate. And more importantly, it's a signal. It's your tooth telling you something. Today, I'm going to explain exactly what that signal means, why it happens, and what you can actually do about it. Let's get into it. Let's start with the mechanism, because once you understand this, everything else makes sense. The outer layer of your tooth is enamel, the hardest substance in the human body, but beneath the enamel is a layer called dentin. And dentin is full of microscopic channels called dentinal tubules that run from the outer surface of the tooth all the way to the nerve in the center. Here's how I like to think about it. Imagine holding a handful of straws lengthwise. Each straw is a tubule, a tiny fluid-filled channel. When something hot, cold, sweet, or acidic hits the exposed surface of that dentin, it moves the fluid inside those tubules. That fluid movement triggers the nerve. That's the jolt you feel. This is called the hydrodynamic theory of sensitivity, and it's the most widely accepted explanation for why dentinal sensitivity occurs. The nerve isn't directly being stimulated by the temperature. It's being stimulated by the fluid movement inside the tooth. That distinction matters because it also explains why certain treatments work and others don't. Now, for this to happen, the dentin has to be exposed in the first place, which brings us to why that happens. There are several ways that dentin gets exposed, and they're not all created equal. I want to walk you through the main ones I see in practice. The first is recession. Gum tissue recedes, pulls back from the tooth, exposing the root surface below. Unlike the crown of the tooth, the root has no enamel protecting it. Instead, the root is covered by a thin layer called cementum. Cementum is far less protective than enamel. It's softer, thinner, and abrades easily. Once that cementum layer wears away, the dentin beneath it is directly exposed, giving you a wide open pathway straight to the nerve. The second is abrasion. This is physical wear on the tooth surface, most commonly from brushing too aggressively or using a hard bristled toothbrush. People think brushing harder means cleaner teeth. It doesn't. It means worn enamel, and over time, exposed dentin. Abrasion tends to show up right at the gum line, a smooth, worn-down groove where enamel used to be. The third, and this one often surprises patients, is abfraction. Abfraction is a stress lesion. It occurs at the gum line and is caused by the flexing forces your tooth experiences during biting and chewing. When you clench or grind, your teeth flex microscopically at their narrowest point, right at the cervical region, right at the gum line. Over time, that repeated flexion causes the enamel to chip away in small wedge-shaped notches. No decay involved, no toothbrush involved. It's purely mechanical stress. Abfraction, recession, and abrasion often show up together, and together they create a perfect storm for sensitivity. Multiple pathways to the exposed dentin all converging at the same time of the tooth. And then there's enamel erosion from acidic foods and beverages, citrus, soda, wine, sparkling water, which can thin enamel broadly across the teeth over time. And of course, active decay or a cracked tooth can expose dentin as well. But those are clinical findings we address directly. Today, I'm focused on the structural, non-decay causes of sensitivity that a lot of patients are living with. Here's something I say to patients all the time, and I think it's worth saying on camera. Finding recession, abrasion, or abfraction in your mouth does not automatically mean we need to do something about it today. Small, stable lesions that are not changing, not getting deeper, not getting wider, not getting more sensitive, can be monitored. We document them, we photograph them, we track them at every visit. As long as they're staying stable, observation is completely legitimate clinical strategy. What we're watching for is change. Change in size, change in symptoms, change in the structure of the tooth. That's when the calculus shifts and we start talking about intervention. I tell patients I would rather check on something for 6 months than do something to your tooth that didn't need to be done. That philosophy drives how I practice. When we do move towards management, I always prefer starting with the least invasive, most cost-effective options first. Here's how I think about it. The first thing I recommend is switching to a low abrasiveness toothpaste. Sensodyne is the name that most people know, but there's plenty of good options out there now. These toothpastes work in one of two ways. Either they deposit compounds that occlude or plug the dentinal tubules, reducing fluid movement, or they desensitize the nerve directly over time. Either way, consistent use over several weeks to months can make a meaningful difference. It's low cost, it's low risk, it's always where we start. The second, and this one I consider essential for almost every patient with sensitivity related to abfraction, is a custom hard dental night guard. Remember what I said about abfraction being caused by the flexing forces in the tooth? A night guard doesn't just protect your enamel from grinding. It reduces the mechanical flex at the cervical area of the tooth. Less flex means less progression of the abfraction lesion. Less progression means less structural loss, and less structural loss means less sensitivity over time. I want to be clear, a night guard is not a cure for existing sensitivity, but it is the most effective tool we have for stopping the mechanical forces that are making it worse. If you've got abfraction and you're not wearing a guard, you are slowly but steadily losing the tooth structure every single night. Beyond these two foundational steps, if a lesion has progressed to a point where restoration makes sense, my material preference is not always standard composite resin. For abfraction sites specifically, I sometimes prefer materials like Gerrestore or similar products designed for this application. The reason is important. Those materials are compatible with gingival grafting procedures if one becomes necessary down the road. Standard composite is not. That means the restorative choice you make today affects what options are available to you in the future. It's worth getting right. Sensitivity that comes and goes with temperature, especially cold, and resolves within a few seconds is typically dentinal hypersensitivity. Manageable, treatable, worth addressing, but not an emergency. Sensitivity that lingers, pain that lasts more than 30 seconds after the stimulus is gone, spontaneous pain with no trigger at all, pain that wakes you up out of a deep sleep, those are different. Those are signs of pulpal involvement. The nerve inside the tooth may be under significant stress. That needs to be evaluated and should be done right away. Sensitivity is common, but common doesn't mean normal, and it doesn't mean you have to live with it. Understanding what's causing it, whether that's recession, abfraction, abrasion, or something else entirely, is the first step towards actually fixing it. Start with a low abrasiveness toothpaste. Talk with us about a night guard if you're clenching or grinding. And if your symptoms are escalating or changing, don't wait. If you've got questions about your own sensitivity, give us a call at 630-963-6750 or visit jacksonfamilydentistry.us. And if this video helped you understand what's going on in your mouth just a little bit more, hit that subscribe button. We've got new content all the time. I'll see you in the next video. Thanks for watching. Bye now.